like I said earlier, it's maybe understanding some of the things that you can do even early on after an injury or an operation. And I think sometimes there's uncertainty or worries about, when I started as a young registrar tip, I was terrified about wrist fractures because I thought, I'll leave it in a class for ages. And, and I would way over-treat most things. And actually, the key to, as you guys probably know, is recovery is actually early movement, mobilising. There are some things clearly that you can't and shouldn't do, can be harmful. So we'll try and go over that. And if there's any area of your practice that you see a lot of wrist injuries or shoulder injuries, and you think, well, what can we and can't we do, then I'll do my best to answer them. I'm not a spinal upper limb expert, but I do a bit of trauma, so we'll do our best. We can go through some of that. And as I say, please just call out and ask questions as we go along. So for electives, so we can split into elective and trauma or injuries. So for my rounds of knees, I mean, if we're talking about knee replacements, all knee replacements get fully weight bear straight away after the operation, right? 100%, unless the surgeon specifically said that was been a problem. But cement takes 9 minutes to set. So before I've sewn up the skin, that knee is ready to take away that patient. The thing that slows them down is the pain, the swelling, the stiffness, and that's where you guys can come in and really help. So if you've got someone who's early on after a knee replacement, the most important thing to try and get them to work on is extension. Okay, because flexion comes. It's the extension early on that really can be difficult to come back. If you get a fixed flexion, if you're going to have 15 degrees, you can't straighten it. That's really horrible to walk on a knee that doesn't straighten fully. So work on extension, and the way you can do that is, the way I tell patients to do it is to sit down with a heel supported on a little stool or a chair. Right? You can let gravity, use your quads to push down. That can be sore sometimes for them, or they can't overcome that. So you can either get a little trick I tell them is to get a set of other gloves, stick it over the thigh, put a couple of bottles of wine in the hands, and use that as a weight. Or get the other half in a bad mood and get them to compress either side and just hold it to a point where they can tolerate, but it's uncomfortable. It's got to be uncomfortable to be doing anything. So that's the straight bit. The bending, the bending, everyone's obsessed with the inflection early on. There's no great rush as long as it's not protracted by weeks or months. But I see people at 2 weeks for a wind check. If they're only at 70 degrees, I think we're constantly worried about it because the flexion will come. The swelling at the front of the knee tends to stop the flexion because it's this tissue at the front that gets stretched, and I find that's the thing that stops them. For an extension, it's hamstring spasm at the back or biceps. Biceps quite common. Quite see a lot of people with postural lateral pain, feel on the biceps quite sore after the knee replacement. That's quite common. But again, I'm teaching my graduate psychiatrists because you guys know far more about that sort of stuff than I do. With hips, I think hips are different. So you can't dislocate a knee replacement by pushing hard, right? It ain't going to happen. If you do that, believe you me, it's not your fault. The surgeon's cocked it up and done a way too big cut, or mismatched it, or done something wrong. Okay, but you cannot dislocate a knee replacement. If that happens, I would be amazed, and it's the surgeon's fault. Okay, so don't worry about that. Hips are totally different. So clearly, hips, and it depends on the approach as well. Okay, so if the surgeon uses a posture approach, you might not necessarily know that, the patient might not know that either. But the posture approach, so that's when we slip the getting back to front, so the hip pops out the back there when we dislocate it. And the danger position is the stepping in a bit of dog shit in the ground. It's that maneuver there. Okay, so you're flicking your heel up and then internally rotating. So it's a combination of flexing of the hip and internal rotation. That is the danger position. And you've got to avoid that in the first 6 weeks, really. Okay, and the easiest thing is to be sitting down and say, oh, just drop something and do that. So as they do that, early on, I don't pause. Okay, and it's a horrible thing to happen in early dislocation. Because it just rips all the soft tissues that are healing after the operation and they're back at square one. So that's probably the most important thing for hips, is to make sure that they get up in the chair, use their arms, step up, keep their feet parallel, and push away, and avoid the twists. Okay, or reaching to get something on the bed and do that way. It's that position. It's internal rotation. Shoulders, certainly with replacement surgery, you've got to open the rotator cuff to get in. And also some soft tissue procedures. I think a lot of the time the shoulder guys use the brace, and I'm sure you see the patient come to your clinic with this. So, you know, that's really something which, in the first 6 weeks, you really can't do much external rotation or resisted rotator cuff work. I think they often have these big cushions under them to stop rotator cuff. So cuff repairs and shoulder replacement. The shoulder replacement as well, they've got when they come in from here, they have to take off the subscap to get into the joint. So the subscap, as you know, internally rotates. So you shouldn't be externally rotating too much because that's going to stretch your subscap repair. Okay, so I think the shoulder, that's when the real dangerous thing. Most things underneath shoulder height, after shoulder, are safe. It's very hard to cock up a shoulder replacement by doing the exercise with here. And you've got to be a little bit careful when you start to come above shoulder height. Certainly the first couple of months. After that, I think most things are good. So you're talking about hips, knees, shoulders.
Listen, Nick, sorry.
Yeah.
Like a typical knee surgery, and the patient comes in, they're under the 6 weeks, and flexion is limited, and you're getting it towards end range, the patient's nervous. I can be a bit nervous as well sometimes because you sort of, I mean, how much are you saying is be a bit more brave with it because you can take it further than you realise?
If they can tolerate it, absolutely. Yeah. So you can't damage them, right? I mean, unless you're being stupid and a little lady's 80 and using your strength, you're not going to do that. But by pushing to a point where they feel the pain and then saying, right, are you ready to do a bit more and going a bit more, that's a really good thing. It just keeps everything straight, it's stopping all that early scarring by just keeping it supple. And that, it's going to help them.
Yeah.
So it's getting them on board and explaining to them, look, it wouldn't snap, it wouldn't damage. Because I think a lot of it is fear. When the damn thing's so stiff, I think people get frightened that they want to keep it like that in case they damage it further. That's just
cartilage repair, that kind of, I mean, let's say you've stitched a bucket handle or something, and you know, is that a different scenario?
So they'll always come out with so the meniscal repairs I do, they always come with a brace, and I keep them in a brace for 6 weeks, and I stop them going past 90 degrees. So I let them weight bear, because if you stand on a tall cartilage that's got stitches in it, that's great for me, because it compresses the damn thing. So you know, those hoop stresses compress because there's a stitch across it. So weight bearing is fine. Okay, this is a root tear, that's slightly different, but most muscle tears respond well to loading. But the deep flexion, remember, if this is someone's tibial plateau, right, and here's my femur, so here's a big flexion move, right? As the particular lateral meniscus, if you could do an MRI, I can't wait for you to do sort of dynamic MRIs, because when we see what the structure of the knee and the hip and the shoulder do in movement, it'll be really fascinating. But if you do a deep squat, if I do that right now, you know, my meniscus is hanging off the back of my tibia, especially on the lateral side. So it's at a huge force. And if I've just done a meniscal repair and they do a deep squat past 90, that's going to really put pressure on my stitches. So that's why I don't let them bend past 90. That's pretty standard for these surgeons to do meniscal repair. After 6 weeks,
is it passive? Is that a different story?
Yeah, it's just that range. You can't. Right. Yeah. So do you like within 90? I just don't like getting past that for the first 6 weeks. After 6 weeks, then get going.
Yeah. Thank you.
So I was going to ask Judy about how you would treat a knee, because obviously Nick refers to you post-surgery. So is there any particular protocol that you use with osteopathic treatment?
I think it's just using everything that we always do and not being frightened of any sort of ruptured anything or stitched anything or broken bones or anything like that. And just going for it and really trusting that, you know, actually what we always do works. And just like loads of soft tissue, loads of like muscle stretching, muscle work, especially hamstrings with the knee, and especially just trying to kind of like MLD for all the drainage, trying to get that, and then movement, a bit of harmonics and a bit of sort of, just getting it all moving, and it just helps so much because physios just don't really like doing that.
I used to give exercise, I think when I see people in the swelling or something that causes pain, so you at least drainage and
Another really good one for knee replacement is immobilising the patella.
Yeah.
Okay, so if you get them to completely relax their quads, a lot of people find that the scarring in the patella and the gutters can really limit flexion. Okay, so if you can mobilise the patella, but you cannot dislocate the patella after a knee replacement. If you do, the surgeon's fault is there. So really getting to work and releasing that can be really helpful. I show people that a lot to do themselves or get their other half to do it for them. So that's something you guys can definitely do nice and early. I mean, even within 2 weeks. I mean,
I was going to say, what time would you be?
straight away. I mean, there's absolutely there's no need to wait. It's just moving it back and forth that way. You can't damage anything.
And obviously, Epigard and all that can be done pretty quickly. It is a drainage, so
Oh yeah,
threw it away.
Yeah. Yeah, absolutely. That's all fine. You certainly can't harm. I mean, we have to open the extensor mechanism to do the knee. I stitch it up with a fairly strong stitch, and we start walking that evening to the toilet. So we're asking to put full weight through that. So if we're happy to do that, you're not going to do anything by even getting stuck in and pushing hard with your thumb. You're not going to do anything. No way. Knees are much more robust than hips. It's just the dislocation I think with hips. But yeah, knees get stuck in as much as you can. It's really hard to undo anything, I think, with manual therapy.
And obviously, due to the process that she sees a much better, they recover much quicker, don't they, seeing an osteopath? Yeah.
It's also people that have been to see physio and they're still struggling and they're still a bit dissatisfied. And then I think, then you can make a difference as well. I had somebody who's come in a year down the line and just like 3 or 4 treatments where nobody's like done any muscle work.
Not
or
the
anything.
hands on, have they? That's
No,
the thing.
no.
That's it. Physio are a little bit do this, do that.
Yeah.
Here's the sheet, do them. And of course, patients do it. Oh, there's next one. Do that. Oh, it's sore. I'll stop.
Yeah.
And they don't. And I think what you guys are good at is actually getting your hands on and saying, right, and it is going to hurt a bit, but it's okay. I wish physios were much more hands-on and pushed a bit harder.
And is there anything that we should worry about? Something that isn't like swelling and coming out? Is it 4 months?
Yeah.
Or what are the things we should be looking out for that might not be going to plan?
I think stiffness is not getting better is always a worry.
Yeah.
Any discoloration, any ooze wound at all, you need to do that straight out. So that's obviously a big concern. I think redness around the knee, redness doesn't last. It should be gone by within a couple of weeks. It should be red anyway.
Yeah.
So that's a slight concern. If you're not winning, if the stiffness just ain't getting better, after a couple of months, then that probably needs to be looked at, because we can intervene, we can take it back to theatre and do manipulation. You can actually, some of the manipulation what they need, they're actually quite satisfying. I don't do many of them, but when you do them, once the anaesthetic's on board and you push, you can put my hand on the patella and I bend it, and maybe if it's a re-stiff, we'll start there. And if you do that, it just goes crackle, 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 and you can hear it, and sometimes the anaesthetist goes, it really is a horrible noise, but you just get all that scar. There's no way that all the manual therapy in the world could release that without an anaesthetic. It's just too small. It jams you, it's physical, because as soon as the spinal anaesthetic's in, or GA, and they're asleep, I'll pick up the leg, and it just sticks like that. It doesn't move. Okay, so it's mechanical. It's painful, but it's just not moving. And then I push gently, breaking anything, and you feel it, and you can hear it crackle.
So is that due to them not necessarily doing the physio, not mobilising?
Usually it's just
so if we can get our
for whatever
hands
reason, they haven't done physio, they haven't been going, too scared, it's too sore, and then just get this vicious circle.
So if we can get our hands on, get it mobilised,
So if you can get
then we can reduce the chance of that.
Yeah. So, just with this trauma, so things are fixed. So we've got a broken thing, we fixed it. Generally speaking, they shouldn't have plasters on anymore, or they might have a supporting bandage or something. But if something's fixed, then by definition, it's ready to get moving. Okay, that's the whole point of fixing things, so you can get early mobilisation. So you've got a wrist fracture. I don't put any of the wrist that I played when I'm on call. I don't put on a plaster, put on a bandage. It's a soft bandage. Get them going, okay? Because it's fixed. So why would we move it? There's no point being a plaster as then. It's either a plaster or you fix it. So I think if something's been fixed, and do you guys get operation notes?
No,
it's quite long, isn't it?
It is.
We would help. We would
Some of
help.
them bring them a photocopy or an email.
Yeah, they'll take a
Yeah.
picture of the screen or something.
Yeah.
allowed to do
I mean, that is a problem actually, because if there's any specific instruction, obviously there's the odd red herring out there, and that can be difficult. But mostly if it's fixed like a tibial nail, if someone's had a fracture nailed or plated, then they're good to go. Get them going. Mobilise their ankle below, get the hip and the knee above it moving, and the joint above and below any long bone keep them moving.
Including, say, like a hip fracture where you've got.
Yeah, all hip fractures have to be moved by full weight bearing straight away. And if for whatever reason they can't, and the fracture fixation hasn't been done adequately or properly, okay, you can't make a 92-year-old with multiple comorbidities weight bearing crutches. You just can't. You can't do it. So you got to fix it so that they can get that walking. Because that's the only way they're going to survive that injury. So it's really important to weight bear all fractures of neck and femur fractures straight away. That's why we do the operation. Get them going.
What about your ankle fracture?
Yeah, so that was my turning moment when I thought, oh, there's something in this osteopathy thing.
You saw the line,
I did, it was a
Yeah, go on
week
then.
moment. No, I was carrying about kids, he's now 15, I couldn't carry him now, but he was 5 at the time. And I slipped on a wet back one night and heard my ankle cracking, I was lying there. He's trying to make some juice, for God's sake, get up. Of course you haven't broken it. Crap. Anyway, so I had an X-ray and then got a plaster there. I had to hack the plaster off after about a day. I just couldn't stand the damn thing. It was awful. Hated it. And so I treated myself completely different to every other patient. Hundreds and hundreds of ankles I've treated. But no, I'm different. And I really wanted to try and move it. But I think it was around about the 2-week mark. It was maximal swelling. And I was just really struggling. I had to pay a fortune in taxis because we used to live out in East Sussex to the hospital every day. And she said, for God's sake, just shut up and come here. And she basically manipulated my ankle. Because the biggest thing that people find after an ankle fracture is coming downstairs. Okay? Because it's that movement, that's dorsiflexion. That's the last thing to come back. And so you walk around not too badly, but you don't have to dorsiflex to do that. As soon as you have a step to come down, your patella comes over your toes, and that's really hard to achieve. And so Jupe, I don't remember what she did, but it bloody hurt. But it instantly sorted out. I mean, that was about 2 weeks, wasn't it? It was quite, maximum, swelling's at the maximum 2 weeks. After 2 weeks, most swelling's now. But she did something which...
It was sort of like shearing,
Yeah,
stuff that we do,
yeah.
like wrists, so wrist fractures and, tibial anything, for just shearing, because I think that's where all the scarring happens, and then you just haven't got a normal functioning joint, or, so yeah, all of that. You can't do that in a boot or a plaster, or, if you're worried about it. So yeah, I think just, don't be so worried. And where it's really painful is exactly where you do have to work and dig in, exactly. And I think it really works, and I mean, it definitely worked for you.
Where was your fracture then? You hadn't been fixated or anything, it was still fractured?
No, I got the guys at the Blushing gave me a
But you had a spinal fracture of your...
fibula, no. But it was, I remember an ankle fracture is it's a soft tissue, it's an ankle sprain with a broken bone.
Yeah.
So that everyone gets fixed, the bone's broken. Actually, it's a much bigger injury than just that fibula fracture, but that's a piece of piss that heals up quickly. It's the soft tissues, it's the ligament and the rib, starting from your ATFL right round your lateral ligament complex. And that was the, I did have a medial side, so it was a stable injury. So I did a weight bearing view to make sure it didn't need an operation. And then I tried weight bearing quite quickly, and it was surprisingly doable. It was just a movement that was difficult. So I had, in bed at night, I used to wear like a little sort of vacuum pump. So it was like a thing that went round, and I think I took a pump.
I think you wore it twice.
Did I? I bought an Andy Murray ankle brace, that was really good. Because he had ankle troubles, I don't know why. Skinner for Andy Murray. But yeah, I couldn't. I tried the walker routes, you see these fixed boots, and they look good, but it's just miserable to wear because your ankles are stuck at 90 degrees. There's no movement there. But I wanted to move it. But yeah, since I broke my ankle, my whole approach to ankle fractures when I see my patients is
So that also hasn't changed your
totally naturally. I said, listen, move the damn thing, do the plaster, take it off at home, walk around in it, it's okay. That's as long as it's a stable injury, and it doesn't need an operation.
But the bone starts to heal very quickly.
Yeah, it does. Very quickly. I think I was going to that. I had a trip to Milan, I was going to some relief charity work about 4.5, 5 weeks after my ankle fracture. So I had this trip booked, broke my ankle. Oh shit, this needs to be better for this trip to Malawi. And so obviously I had a CT scan about 2.5 weeks after the injury to make sure it was healing. And already, in 2 and a bit weeks, there was a great big lump of callus in the middle. So it was already, it's amazing how the body can do that. But yeah, Only for a plain one, and I wasn't much fun. So that's yeah, that's so if basically if a fracture's been fixed, I think you can pretty much go to time and confidently get the joint moving. If it's an elective operation where there's a risk of a dislocation or a tendon torn, then you just have to, you really have to know what the surgeon's done, I think, before you start. Anyways, because you can't harm a few things, but most things, like most injuries, can be if it's operations that you're doing this, sort of doing this for the shoulder, have a subsequent repair. You don't want to do this with the hip. It's just basically, things probably that.
You said about having more information, so can we get the patients to ask? That's
Yeah.
what they're allowed to have.
Of course.
They're allowed to have
Yeah, absolutely. Yeah, absolutely.
discharge notes.
Yeah.
So-
Or you know, I mean, I try to give a copy of the operation note as well. Because, you know, all my private patients get a copy of the notes, so they can show to physios, osteopaths, whoever they see. Was there anything else that
Any other
on that
questions
vein
about, yeah,
of that?
post-treatment? No?
In terms of getting those, is there any reason why the NHS don't want to give you that information or let you take the photos of the X-rays and things like that? 'Cause I,
Yeah, it's a bit. I mean, I let my patients in because
Yeah.
it's their X-ray.
well, exactly, that's
It's
was
their
my
problem. GDPR is their problem because it's their information.
Yeah.
So they can show it who they want. That's up to them. But
Yeah.
I mean, it's their X-ray. And if they get the first thing, George, do you mind if I? Yeah, it's yours.
Yeah.
Do it. But yeah, some people get a bit funny about it.
Yeah, I mean, certainly for kids, it's been the kids, they've not wanted me to take pictures of the evidence that, you know, I can go and then discuss with people, potentially.
Yeah. Yeah, no, it's just a thing. I mean, it's just everyone's just so scared of being sued about GDPR and data and things like that.
But you can insist, can't you? Like if you know somebody's going back for an appointment of a follow-up, or you know, and they just say, look, can you just take a photo? And they said, oh, I wasn't allowed to last time. And you just have to say, well, you know, you can insist.
Yeah.
And they can't say no because it is
Yeah.
their X-ray.
Yeah.
So
The thing that I've been heard is that it's just like, oh, it's already gone.
yeah, but you take a photo of
Yeah,
the
but
screen.
actually, you're heading towards it with your phone.
Yeah.
It's already gone.
Well, it's mine. That
Bring it back here.
Well, I say, yeah, exactly, and then show.
Press a button.
this
Can I
is-
speak to your boss? Not
Yeah,
my
shall I
ex,
have the
isn't it?
screen fit now, or shall I just let it go?
Yeah, I think that's just an ingrained sort of, you know, power thing, isn't it? Yes, because people are in a position of power, the nurse, the doctor, and you can't see your picture. So I always have choices off, and I take substitutes because I always like examine the pulses, especially if we're talking about replacement. I need to know the pulse of the feet. So I like to expose, and if you know, the girls think bring shorts or something, that's really helpful. And you need to be able to see the quads. That's just the usual thing. So standing in front of the front. So just can everyone see? Come further down if you can. So things that I look for, I always stand up before I am done. I'm looking for alignment. So if maybe pretty neutral, maybe very mild valgus, I'd say.
No, it's perfect.
So maybe mild valgus alignment, and your scars with obvious muscle wasting or differences, quads and his calves in the back. So that's, you just get a general idea of what you're looking at. Is there an obvious side difference? So that's the inspection. Right, come on.
Come back.
Yeah, line it back. So on this side. So I'll take you through this sort of general way I examine a knee for arthritis, and then we can talk about special tests for ligaments as well, and the menisci and things like that. Yeah. So I always start off coming to the end of the bed, and I just what I do is I take the feet and I just have a little look, and I lift up the heels. And I'm looking for excessive recurvatum on the side, so you can do a PCL injury, and I just get an idea of symmetry on the end of the bed. And look at the quads. You can compare: is there an effusion just by looking? And then I come on to the side of the knee. So the first thing I look for is an effusion. Okay, so if there's an effusion in the knee, there's definitely something wrong with that knee. Okay, it's not referred pain, it's something wrong with that knee. It's a really, really important sign, I think. Now, if it's clearly massive, then that's easy to spot, right? The trick is picking up the subtle ones. And the way I do the test for an effusion is dead simple. So remember, the joint capsule starts at the level of the joint. Okay, so the capsule doesn't come any further down than the joint line. But superiorly, it goes all the way up to well above the patella, up here somewhere. Which is why, when you have a fusion, people say, oh, it's a bit puffy, and they always point to here. Because actually you can feel in the lateral gutter, the capsule comes all the way up here. Right, but you see people sort of sweeping down here. What are you doing? Because the capsule starts there. So to detect an effusion, I do a medial sweep. So what I'm thinking about is, here's the capsule. If there's any fluid in there, I'm going to sweep it. So it's not going to go squishing all around here. So I sweep up there, and then I put my hand on the lateral side and I just push gently. And if there's a little bulge there, then that's an effusion. And that's a really simple way of doing it, but it works. If you want to accentuate it, you can empty the capsule, the suprapatellar pouch superiorly, but you can do it that way. So I do that, and I just push my thumb there. You do have a small effusion.
Not perfect.
Okay, well, we've got a real patient pathology. Tiny effusion. Okay, so you can come and have a seat with this there. Is you really sore? Good. Right. so test for effusion. In the textbooks they talk about the lot of tests. I don't use that. I mean, if you go at patella and you push it down against a bunch of fluid, then it's going to be absolutely massive. You're going to spot that. That for me is the most sensitive test. Okay. Right. So that's the view. Right. Then movement. Okay. So coming from the side. Have a look. Is the back of the knee on the bed or not? There's a flexion deformity there. Can you push right down into the bed? Yeah, so he can push my fingers into the bed and compare with the size. Okay. The only little slip up with this is that if he's got a hip arthritis, his hip's going to be flexed. Okay, so you might say I can't. And you think, oh, he's got a knee problem. Actually, you might not. Might be the hip. The way around that, it's easy. Put the femur and the knee on the edge of bed. And then see if you can straighten. Okay, because you've eliminated the hip arthritis. Okay, so just take it to the side. So, and I just like to get an idea of range of motion. So that's the, can he full extend, can he hyperextend? So, how many fingers between the heel and the bed can I get for hyperextension? And then I take them to flexion. 130 degrees is normal. So take them all out to flexion. Here I go, let me know if it is like that. Okay, so I get an idea of the range of motion. I generally do this all actively myself because it's quicker. My energy is just absolutely bonus. So I do have the time to, in an exam, I come in and ask the patient to do it themselves. But I just get on and do it, just do it for them. And watch the face and see if it's true. Okay, so that's the range of motion. Now, I'm feeling crepitus, so I put my hand on the patella because patellofemoral crepitus is really easy to feel just by doing that gently. Okay? When it comes to the medial and lateral compartments, you want to try and stress those sides of the joint to see if there's any pain being produced, okay? So, for a varus, medial arthritis, I want to be that kind of pressure. I'm trying to compress this tibial plateau onto this femoral condyle, okay? So I'm putting, this hand is putting towards you, and my hand here is putting towards me. Okay, so I'm pulling into varus, and I'm trying to load it. And the other way to do it, I think so I just put my hand there, and I put my knee against my thigh, and I just do that. And if you do that and watch them, that can really solve arthritis. Yeah. And then conversely, for the other side, you put them to valgus. And I'm pushing that way. You can load the lateral compartment. And if I'm talking about people, if I'm thinking about an osteotomy, I'll say to them, let's say they've got classic medial arthritis, right? And I'll do that, and they say, oh wow, that's really sore. Sorry. And I'll say, how does this feel, right? And I'll put them to valgus like a knee brace would, and I'll do it. And they invariably say, well, that doesn't feel too bad. And then I say, well, that's what it might feel like if you do an osteotomy, because I'm changing your alignment. That's quite a nice thing to do. So that's movement. Right, feelings at joint line. Okay, so feel around the joint line. I tend to warn I'm going to perch near the foot. So, is there much to feel around the knee? Well, there's a bit. Tibial tuberosity you can feel. Some kids, Osgood-Schlatter's disease, they get a bit tender around there. Patellar tendon. I mean, patellar tendons aren't usually sore, but the fat pad, Hoffer's fat pad, sits behind the patellar tendon. And I find that that's sometimes quite a good way of pushing the mid-tendon, and they have pain there. Often done easier in extension because the patellar tendon is a bit more lax. Okay, once it flex up, you tense that harder, but you can elicit pain in the mid-tendon. And the jumper's knee. Okay, so jumper's knee is classically the inferior pole. and it's a specific point. And if you get pain just as the tendon emerges from the inferior part of the patella, you've got a jump knee. That's a clinical diagnosis. You sometimes see it on the scan, but that's a clinical diagnosis. It's easy to make. You have to do an extension. If you get into flexion, it's just too taut. You can't feel. You can't listen to that. So that's the sort of front of the knee. Then coming further up, of course, you've got the quads tendon. So any quads tendinopathies, quite rare. I don't see very much, but you know, get an extension again and feel around the superior part of the patella. Right. So back up into flexion. So we've got the medial joint line. So to feel the joint line, there's two soft spots either side. So the patella's here, two soft spots, and you can, my thumb is just falling onto the tibial condyles. So I know that that's the joint line, and I can feel all the way around to the back. Okay, so if you've got arthritis and you're pressing it there, it can be tender there, or if you've got a meniscal tear, that's the other thing that can be sore. Okay, so your feet just direct pressure, and then do the same on the lateral side. Proximal fibula is easy to feel. It's much further around the back than you think. Okay, so it's really quite posterior. I feel around that. And that's really the feeling bit done, right? So that's the look and the feel and the move. And then special tests. So the special tests are the ones that everyone gets excited about. So for the meniscus, so there's loads of different tests. And McMurray's test is done by different people in all different ways, right? So the way I do it, I do a couple of things which I find really quite sensitive. So I do a little sort of cheeky hyperextension thing, especially for medial meniscal tear. So I have my bit of pressure there, and I look at their face, and I'll just do a little forced extension. Okay, now that's the medial meniscus particularly is quite adherent to the joint capsule. Lateral meniscus is all over the place, loose, but the medial one's quite fixed, which is why it's prone to injury more. And if you do that, what you're doing is you're stretching the posterior structures, the capsule, and the posterior on the medial meniscus is by far and away the most common meniscal tear that we'll all see all the time. 85% posterior medial meniscus. Okay, lateral meniscus tears, but they're rare. So there's your sort of bread and butter meniscal tear, and that can be uncomfortable. And then the other one I do is the McMurray. So everyone does it differently. The way I do it, I'm having everything relaxed, flex the hip right up and the knee right up, and I'm doing a circular motion. I'm trying to provoke discomfort. Okay, usually it's a deep flexion. You've got to get quite flexed up. And so I'm doing a flexion and a rotation at the same time. Okay, I don't find this helpful on the way down. I just find it much better in deep flexion. So remember, the posterior horn of his menisci now are sitting right at the back of his tibia. Okay, and then what I'm trying to do is catch them under the condyle of the femur. And that's my two examinations. The other thing we were talking about earlier is there's a thing called the duck walk. Okay, so you get them to squat down like a duck. My colleagues do this all the time. I don't do it so often, but if you're not sure, you can get to do that. See, like walk across the room like this. Okay, and that's quite a difficult thing to do. If you've got posterior horn meniscal tear, you won't be able to do that. That's going to be really. It's quite a good little test to do. So if we were talking earlier, ask them to do that. You might get down to there, so not on your nelly. So it's quite a good way of doing that. So that's the menisci. Did you want to say that? Collaterals. Okay, so the medial lateral collaterals. Now, the medial is really important. Lateral collateral ligament injuries are extremely rare. Okay, and occasionally get said them. There's always a lateral collateral. The lateral side is much more lax than the medial side. Okay, so there is much more opening of the knee anyway when you strain the lateral collateral ligament. Okay, a fair bit of movement there. Okay, so I think it's always important to compare the other side. But for the medial collateral ligament, you want to have about 15 to 20 degrees of flexion. Okay, and I'm just putting a little bit of valgus pressure on the knee, and I'm just feeling how much it's opening up. If you go into full extension and do it, you're not really testing the MCL. The posterior oblique ligament is right around the back, and if you've got a knee that opens up with full extension, that's a bugger knee, that's really badly injured. Okay? Very unusual to get that. It's a major stripping of all the medial tissues. So, to get the MCL in isolation, flex about 15-20 degrees, and then you're just doing a little bit of that. Okay? And we're all different, so some lax people have maybe 4 or 5 degrees. And most males of a certain age will be stiffer, like me, and you're somewhere in the middle. Right? So that's the medial, and then the lateral side, you're feeling for an end point and compare the other side. So that's the collaterals. And then the cruciates, so I don't really do an anti-drop, but the ACL and the PCL, I use a lot. Okay, so lockment is when you get, it's critical to get them relaxed. Okay, because as soon as they tense up their hammies, you're not going to get any meaningful. So I always have a pillow. I always have them as flat as possible. And I often have to tell, especially kids, about 4 or 5 times, don't end the pillow, because they just lie down. Because they want to live, they want to see, right? Especially parents that have someone with them. And you sort of have to tell them several times, just put your head down, because it relaxes their tummy muscles and everything's relaxed. Okay, because the hamstring then has a spasm, and you can just check. So, how lovely candidate is, lovely relaxed. So, a Lockman test. This is one of the best bits of advice I was given in my fellowship was, imagine you're trying to pull his tibia over your shoulder. And that's the kind of direction of travel. Okay, so here's his femur stabilised, and that's what I'm doing. Okay, I'm not doing this with this hand. This is static. This is not moving. And that's my movement for his cruciate. And what I'm trying to feel is I'm feeling for a snap as the ACL gets taut and stops. That's what you're feeling. You can go back the way for the PCL, but as far as sort of true PCL is concerned, the posture draw really is a good test. So you always want a patient, you're going to sit on the foot. Okay, you're going to stabilise that. Now, from the side, you're looking at a PCL injury. If the PCL is ruptured, this tibia is going to fall in that direction. Okay, and the tibial sag is what you can see some nice pictures of looks at this. Great big thing, right? So the PCL test is called a posterior draw. So what you want to do is make sure the hammies are relaxed. I always check the hammies and the biceps are nice and relaxed. And then you're feeling for a station. So my thumbs are on the femoral condyles, and my thenar eminence is on the proximal tibia. And you pull the tibia forward to its normal position, and then you're pushing backwards. You can see how far back it goes. Grade 1, grade 2, grade 3, and it's measured in millimetres. Okay, and that's my PCL test. It's a posterior draw. You get an idea with the Lockman, because the Lockman you can do both. But really, that's my workhorse for the ACL, and that's my PCL test. Okay? PCL is quite a rare injury. Pivot shift is a hard test to do. If it's positive, it's 100% sensitive. Okay, so normally you cannot have a pivot shift. So if you've got a pivot shift positive knee, that ACL is not functioning. Okay, you need an MRI scan. It's 100% not functioning. Okay, so it's a non-functioning ACL, and it's quite hard to do in the conscious patient. So when they're asleep, it's easy. But the key again, like with any, is having them relaxed. Okay, the pivot shift is a combination. So you want to have a little bit of internal rotation of the hip. Okay, valgus, so I'm pushing in that way, and then it's just in the first few degrees. You see these people coming in, I'm going to pivot shift, clump. I mean, it's just, it doesn't work, it's horrible. It makes the patient unrelaxed. It's a horrible thing to have a pivot shift done to you. Because basically what you're doing is you're starting with the knee. If your ACL was ruptured, his knee is now partially dislocated. Okay, that's what the pivot shift is. And the clunk is the knee jumping back into position as the ITP flips over the axis of rotation. So it's not a very nice sensation to have it. Some people let you do it lots and lots of times. You bring all the medical treatments and the rituals into see. But most people don't like it. You get to do it once. Okay, because once you've done it, they go, oh, no, and then they tense and then that's it. So it's really important to surprise them, not tell them what you're going to do. Get them relaxed. Internal rotation of the hip, bit of valgus, and so the first 10-15 degrees of flexion. You don't have to, up here, you've missed it. You won't feel anything. So it's just 10-15 degrees. And what you're feeling is just a clump. Has anyone got an ACL rupture? Sure. So that's the pivot shift test. And it's a great test.
Do you want to talk for anything? I think you've done it before, haven't you?
So yeah, menisci, collaterals, pivot shift, and then, I mean, it just has to be said, so especially in kids. Please don't forget the hip. Okay, especially in kids. A number of times that some of the knee problems the hip kids. And I'll get 10 people a year that come and say to me, and it's actually a hip, basically, not the knee, because of referred pain. So always just check the hip. Check the hip movements. Always, especially if it's a knee replacement, I like to feel the posterior tibial and the dorsalis pedis arteries. So is there anything there? You want to practice? Do you charge?
Okay.
Oh, you should charge. I'm ready.
I'm ready.